discussed organs that there is. I mean, most all of them that we're going to talk about are important in one respect or another, but we're going to be talking about the stomach and the intestines today. Now, there's information about the mesenteries and the omentum, or the omenta, and those are supporting structures to the stomach and the intestines. But I figured that what we could do is go through this first, the real prominent features, and then go back to some of the supporting structures if time allows, and if not, we'll hit it in another video. But wanted to cover the major structures first, rather than the supporting structures, and then trying to build up to the main stuff. I wanted to go the other way around. My videos, I get to choose, so that's just part of it. Speaking of my videos, if you like these videos or other videos like it that you've seen, please leave a like. If you would subscribe if you haven't already, so that you can see more videos whenever they come out, that'd be great. And again, if there is somebody else out there that you know that enjoys ASMR like this, feel free to share with them. Share the wealth, hopefully, if you view it that way. As always, I really appreciate everybody taking the time to watch. Now, with that out of the way, let's go ahead and get into the stomach. We're going to start with the stomach, and we'll move on to the multiple portions of the intestines, which we'll talk about here shortly. So just as a reminder, we have the quadrants, the right upper quadrant, the left upper quadrant, and then the right lower and the left lower. The stomach is going to be occupying space in the left upper quadrant, and basically that just means that if you cut your abdomen into 4 parts, it's going to be in the upper left portion. And then this is just showing the transpyloric plane, which is just another dividing line for some structures when you're orienting yourself, especially on like imaging. And now we've got a transverse section, inferior view. So we've cut the stomach in half and we're looking up from the bottom. Or we've cut the body in half and we're looking up from the bottom. So here's the stomach, again in the left upper quadrant. And then behind that is going to be the omental bursa here. And then we've got the spleen off to the side behind the stomach. And then the kidneys are further back, or this it's called retroperitoneal. And then the inferior vena cava is here, the liver is here, taking up a huge amount of space at this cross section. So just to give you an idea of where everything is, so the liver is going to be over here, the stomach's here. And then we actually have got relations of the stomach, and it's got basically, what it's bordering, so that whenever they're referred to as the such and such surface, you can know what we're talking about. So you've got the esophagus, of course, leading into the stomach. The hepatic surface is that's going to be bordering the liver. The phrenic surface is going to be on the lateral side, and then the epigastric surface here is going to be on the bottom. And then and this is an anterior view, from a posterior view from the back, you've got the phrenic surface that you saw laterally here. You got a splenic surface, because again, it's bordering the spleen here. That relationship is shown. You've got a pancreatic surface, so the pancreas is sitting behind the stomach, or below it, behind and below. And then the colomesocolic, say that 5 times fast, surface on the bottom, so bordering the colon. And then just the very vestiges of the hepatic surface over here. Now the stomach, as far as broken down into the portions that make it up, you've got the esophageal portion, you've got the fundus, which is this top, and it's got the little dots here to show us the sections kind of cordoned off. You've got the cardia here, the lesser curvature, and if there's a lesser, that means there's going to be a greater. So the greater curvature is here. The pyloric canal, and it's called the pyloric canal because it leads to a structure here called the pyloric sphincter. And a sphincter is just a muscle that closes just like this. And it'll open to let things through, and then it'll close again. Well, this pyloric sphincter leads into the duodenum, which is the first portion of the intestines, the small intestine. And then you've got the pyloric antrum here, which is just kind of a receiving area prior to that digestion stage. So now we've got, and this is the anterior wall, or the outer layer. Here we've got the muscular layer, and what's been removed is the serosa and the subserosa, which is basically just the skin of the stomach, if you will. And then they're using an endoscopic light source just to show, endoscopy is when the patient is fed a tube down the esophagus to go in and look and see what's going on in the stomach. So we've got an endoscopic light source here. And then here's the adventitia, the outside, the muscular coat, the longitudinal layer here. And then the muscular coat is actually comprised of an outer longitudinal layer, a middle circular layer, and an inner oblique layer. So kind of 3 layers of the stomach, because the stomach really is kind of a giant acid-filled muscle that is taking and receiving the food we eat and beginning the digestion process and then passing it on to the intestine for further digestion and absorption. There's that pyloric sphincter I was referring to. And then here in the inner portion, so what's been removed is the entire anterior wall. And then it's got these are little folds here are called rugae, R-U-G-A-E, rugae. And it says the body of the stomach with the longitudinal rugal folds, or rugae. There's the interior notch, that pyloric sphincter, and the pyloric orifice here, which is again just that opening to receive it. Coming over here, it says the stomach resides primarily in the left upper quadrant, which we covered. It is intraperitoneal, and its mesenteries being the lesser and greater omenta, which again we'll get to a little bit later. But so we're having this kind of resected back, and you can see the liver is being pulled back a little bit because otherwise it would lay on it, which makes sense again. The hepatic surface, that's this whole surface, is bordering the liver. So we've got it pulled back, and we can see the falciform ligament of the liver, which is a major attachment point, and then the round ligament as well. We've got this is just the liver as a whole, and it's got the different lobes indicated, but I'm going to go ahead and gloss over that because we're talking about the stomach right now, and we'll get to the liver later. I'll highlight this green guy here is the gallbladder, so anybody who's had gallbladder surgery, or what's medically called a cholecystectomy, that is gone. So, and we'll get into that soon. Here we've got, as part of the lesser omentum, you've got the hepatoduodenal ligament and the hepatogastric ligament, and it's just a ligament attaching those structures. The fundus, the cardia, and the body of the stomach. Here's the spleen tucked back here. Here's the lesser curvature, and then the greater curvature over here. The descending colon, which makes sense because it's got the colomesocolic surface, that bordering portion right here on the bottom and posteriorly. And then the transversus abdominis, if you thought you were getting away from the oblique muscles, there they are again, or the abdominal muscles, there they are again in relationship. Here we've got a good high quality clinical box. As shown here, this endoscopic light source. Why are those used? Why is that done? Usually this guy right here, gastritis and gastric ulcers. Gastritis and gastric ulcers, the 2 most common diseases of the stomach, are associated with increased acid production and are caused by alcohol, drugs such as aspirin, and the bacterium Helicobacter pylori. And you'll hear that more commonly shorthand referred to as H. pylori. Symptoms include a lessened appetite, pain, and even bleeding, which manifests as black stool or dark brown material, often described as resembling coffee grounds. Now the reason for that is, and this is an important thing clinically, is whenever it's a coffee grounds in the stool, that means that the blood has been digested and kind of broken down by the natural digestive processes. So you know that the bleed that's taking place is higher up in the digestive system. Whereas if you have bright red blood that's coming, that means that it's either lower in the intestines or could even be something like hemorrhoids or something like that. So kind of an easy way to rule that out, and that's why they take the time to indicate the coffee grounds portion. Gastritis is limited to the inner surface of the stomach, whereas gastric ulcers extend into the stomach wall. The gastric ulcer in C is covered with fibrin and shows hematine spots. So there's those rugae, what we saw here. This is normal stomach, normal pyloric antrum, and then that ulcer, which is just kind of being eaten away by the excess stomach acid. So it's how the body's supposed to be naturally, but then in the instance of things like that, that's your body in overdrive for some kind for whatever reason, whether it be stress or the different things that were indicated, like alcohol or medications. All right, now we're getting into the small intestines, and it's going to go section by section. And I say section by section because there are 3 sections to the small intestines, and we'll read about it here. The small intestine consists of the duodenum, the jejunum, and the ileum. The duodenum is primary retroperitoneal and is divided into 4 parts. So you've got 3 divisions, and the first division has 4 parts: a superior, descending, horizontal, and ascending portions. So duodenum is here, and then the jejunum and the ileum are further on down, which is crazy when you see it like this, just how packed in it is. We'll get into it though. So the parts of the duodenum, it runs in relationship with the inferior vena cava, but it has a duodenal bulb. Here's the superior, or first part, a flexure, the descending portion. So again, superior, descending, horizontal, which is here, and then ascending. So basically it's just saying that the duodenum has an upper portion, a part that goes down, a part that goes across, and a part that comes back up. That's what it's informally saying. And it's, again, also in relationship to the arterial structure of the celiac trunk coming off of that abdominal aorta, as far as relationships go. Continuing on with the duodenum, so you've got the pyloric sphincter, which we talked about for the stomach, going into the duodenum. We've got bile ducts right here, which are important because the bile ducts put out bile, which assists in the digestion of fatty stuff in our food. And let's see, circular folds, which at this point are called the valves of Kettering. We've got the accessory pancreatic duct because the pancreas is going to provide insulin and regulation of blood sugar in response to the food that's going through the intestine. You got the minor duodenal papilla. Here is the main pancreatic duct. Let's see what else. The muscular coat of the intestines has a longitudinal and circular and submucosal layer. So innermost, middle, and outermost. And then that is going to then lead into, after the ascending portion, there's a duodenojejunal flexure. Not something I'm saying every day, so I have to double check it. And then it's leading into the jejunum. And the duodenum in C2. It's an anterior view, and we've got all the major organs removed: the stomach, the liver, the small intestine, and the large portions of the transverse colon. What has been thinned is the retroperitoneal fat and connective tissue. So now we've got a clear line of sight on the spleen. We can see those hepatic veins for the vena cava. The diaphragm, of course, as far as orienting ourselves. With the stomach out of the way, we can also see the pancreas here. We even have line of sight on the right kidney in the back. And then what else? I mean, really, here's your duodenum starting right here, leading up, and then it stops here, which is where the jejunum will take over. Alright, now we've got another clinical box. 15.2. An endoscopy of the papillary region. Endoscopy of the papillary region. So let's get into this. 2 important ducts end in the descending portion of the duodenum: the common bile duct and the pancreatic duct. So the descending portion, so we're looking right in here. These ducts may be examined by X-ray through the endoscopic retrograde okay, I'll try again. I didn't take it seriously. Cholangiopancreatography, or again, how you will only ever hear it referred to, because no one's ever saying this, is ERCP, and this is when dye is injected endoscopically into the duodenal papilla. Duodenal diverticula, generally harmless outpouchings, may complicate the procedure. So this is all part of the endoscopy. They're trying to rule in or rule out the presence of those gastric ulcers, or here's the endoscopy, and then here's the X-ray portion. All right, continuing on. So the latter portions of the small intestines are the jejunum and the ileum. So let's see the location. It's an anterior view. The intraperitoneal jejunum and ileum are enclosed by the mesentery proper. So not something you easily have line of sight on because this mesentery is overlaying it protectively. So the jejunum and the ileum, as you can see, they really occupy the lower quadrants here. The wall structure, the jejunum has circular folds, and then you'll kind of know when you're transitioning into the ileum because of the presence of lymphatic follicles, or also known as Peyer's patches. Let's see. As far as what to show you here, I mean, yeah, this is the jejunum, so we're definitely out of the duodenum here. We've got the mesocolon, which is here, and then the ascending colon at the end of the small intestines. The tinea coli. We'll get into the large intestine here soon. Let's see. I think that really shows everything I wanted to talk about as far as the relationships there. Another clinical box. We're on fire with those. There's a lot of things that could go wrong with your digestive system. I'm sure you all have heard of Crohn's disease before. It's a chronic inflammation of the digestive tract, and it occurs most often in the terminal ileum, so meaning the end of the ileum, at least 30% of cases. Patients are generally young and suffer from abdominal pain, nausea, elevated body temperature, and diarrhea. Initially, these symptoms can be confused with appendicitis. Complications of chronic inflammation and Crohn's disease often lead to fistula formation, in this case, an abnormal passage between gastrointestinal regions. So, again, if that wasn't clear from this indication, a fistula is whenever there's suddenly a connection point between two parts of the intestine that did not exist before and that do not need to exist in general. They're definitely problematic. So this MRI of the pelvis is showing a thickening of the wall of the terminal ileum, and then a double contrast radiograph is showing an ileorectal fistula. So it's called ileorectal because it's going between the ileum and the rectum. So it's kind of bypassing some of the digestive processes here because of this fistula. All right, the mesentery of the small intestine. Removed again is the stomach, the jejunum, and the ileum, and reflected back as the liver. And so the mesentery again is a supporting structure of the small intestine. So let's see what we want to get into here. I guess for orienting purposes, here's the duodenojejunal flexure, and then here is the horizontal portion of the duodenum. The colon has been kind of transected and laid back here so that we can see more. But here's the mesentery, a cut edge of the mesentery, and a cut edge of the sigmoid mesocolon down here, which leads eventually to the rectum, and then allows for voiding from there. Let's see, we've got the cecum, the appendix, and the colon. And I think that this will be the last that we talk about because after this it really picks up with the liver. And I think we'll talk about, after talking about the liver, we'll talk about some of the supporting structures for the stomach, the small intestines, and the liver, being the omenta. The ascending and descending colon are normally secondarily retroperitoneal, but sometimes they are suspended by a short mesentery from the posterior abdominal wall. And it says, note, in the clinical setting, the left colic flexure is often referred to as the splenic flexure, and the right colic flexure as the hepatic flexure, which makes sense as far as their approximation to those organs. So clinically, or medically speaking, it's easy to just say, oh, well, this flexure, it's a colic flexure, but it's right by the spleen, so we'll call it the splenic flexure. Oh, this flexure, it's right by the liver's right here, so that's going to be the hepatic flexure. But the large intestine, we're looking at the quadrants here. So we're really in all four quadrants. Let's see what's in each quadrant. So we've got the ascending colon here, abdominal sections. So we're here at the ascending colon, and then it is leading into, let's see, the iliopapilla and the ileocolic labrum. They are compose the superior lip and the inferior lip of this juncture between the cecum and the ascending colon. Let me double check something. Double check one thing. Yeah. So really this is just the relationship of the transition between the small intestine into the large intestine. So getting into a later stage of the digestive process. So that's where this exchange takes place. The terminal portion of the ileum. So this right here is this view, that kind of handoff and exchange into the cecum, leading into the ascending portion of the large intestine. And then there's your veriform appendix with the orifice. And if I remember correctly, veriform, I'm pretty sure that means we don't know what it does. I'm pretty sure that what that word means. Correct me if I'm wrong, but basically we don't know what purpose the appendix serves. It ruptures in a lot of patients. It puts them in a bad way, and it's especially dangerous because patients will experience sharp pain in the right lower quadrant because that's where it's at down here, and then all of a sudden the appendix will burst, and the patient will feel relief because the source of their pain is gone. But what's unknown to them is that there's actively digestive matter being spilled into their body cavity, and that can cause sepsis and death. So it's a real serious thing that they take these kind of concerns seriously, and that they not just, if they suddenly feel better after feeling terrible, that's also alarming because it probably means that the appendix burst. So PSA, a PSA that you didn't necessarily come to this video looking for. Let's see. So yeah, the cecum, and now we're into the ascending colon, and then the tinea coli are kind of a supportive structure that helps the large intestine maintain its shape. There's that flexure. The greater omentum, which is kind of that apron, has been cut off here so that we have a view. And then these bulges here are called haustra of this muscular structure. And this is all the transverse mesocolon here, leading to the splenic flexure, to the descending colon. And then there's these semilunar folds that are in between the haustra that kind of define the shape. Here's the epiploic appendices here. This is the sigmoid colon, and then leading into the rectum, and then ultimately voiding. Large intestine in situ, reflected the transverse colon and the greater omentum, and removed is the intraperitoneal small intestine. So the ileum, jejunum, and duodenum have been removed out of the way so that we can see the colon in all its glory. Again, not really anything that we haven't looked at already. Cecum, ascending, flexure, transverse, flexure, descending, sigmoid, rectum. So, clinical boxes. Again, we are chock full of them today. Chock full of them. 15.4 and 15.5. Ulcerative colitis is a chronic inflammation of the large intestine, often starting in the rectum. Typical symptoms include diarrhea, sometimes with blood, and again, probably bright red blood because it's late in the digestive process. Pain, weight loss, and inflammation of other organs. Patients are also at higher risk for colorectal carcinomas, which is just a specific type of cancer of the intestines. Here's a colonoscopy of ulcerative colitis. Kind of gnarly looking. And then here's early phase colitis, double contrast radiograph, and anterior view. And then this colorectal carcinoma that we were talking about here, this is the clinical box over here. These are malignant tumors of the colon and rectum, and they are the most frequent solid tumors. More than 90% occur in patients over the age of 50. In early stages, the tumor may be asymptomatic. It's dangerous. Later symptoms include loss of appetite, changes in bowel movements, and weight loss. Blood in the stools is particularly incriminating and necessitating a thorough examination. And this is age of 50 are recommended to get a colonoscopy. I mean, women too, but men especially. Hemorrhoids are not a sufficient explanation for blood in stools unless all other tests, including a colonoscopy, there you go, are negative. So here's a colonoscopy of a colon carcinoma. The tumor partially blocks the lumen of the colon. And I think we're looking at this structure right here specifically. Kind of gnarly looking guy right there. So, plenty of interesting things to talk about, plenty of things that could theoretically go wrong in our digestive system, but it's a fascinating system that works in conjunction with each other portion. I think we'll draw this video to a close here. Next time we'll talk about the liver and then some of the supporting structures that we glossed over before, being the omenta, to support the stomach and the small intestine and the large intestine. So, as always, I hope you enjoy these videos. I hope they serve to be educational and also relaxing. And if you're looking for sleep, I hope this is a place that you can come to find it. Thank you for watching, and look forward to seeing you next time. Have a great rest of your day.